Good morning, everyone. So I have the pleasure to introduce you to Dr. Roberto de la Rica. Some of you may know him because he did his PhD thesis with us at the Chemical Transducers Group under the supervision of Tony Baldi and myself. But this was a while ago, like in 2007, I think. So Dr. Roberto de la Rica is currently working as the coordinator of the Multidisciplinary Sepsis Group at the Institut d'Investigació Sanitària i Balears, thanks to a Radix fellowship. But his research career is very large. He has a strong international character. He held different postdoctoral positions in renowned institutions such as the City University of New York, the University of Twente, the Imperial College London, and the University of Strathclyde in Glasgow. He's been awarded a large number of research fellowships and academic prizes, including highly competitive positions such as the Marie Curie Fellowship and the Ramon y Cajal Fellowship. So he currently supervises a group of 8 chemists, biochemists, and engineers working in close contact with a group of 17 doctors and nurses in order to find new ways to improve sepsis care. So, Roberto, cuando quieras. Thanks for being here. That's what I wanted to say as well.
Okay, thank you, Cesar. Thank you for inviting me to talk and to show you what we're doing in the last few years. So my name is Roberto. I work here at the Health Research Institute of the Balearic Islands, or for short, IdISBa. IdISBa was created actually not too long ago, like 6-7 years ago, with the idea of joining together of the medical research that was doing in the it was being done in the Balearic Islands, which was actually a lot of research in that area, and it brought together 2 university hospitals, the full primary care system of the Balearic Islands, the blood and tissue bank, and the university. IdISBa is quite potent publication in doing research. We publish about 500 papers every year. We have a lot of clinical trials, which is a very good source of funding. And we are Instituto Acreditado, or an institute with an excellent label from the Carlos III Institute of Health here in Spain. Within IdISBa, you may find the Multidisciplinary Sepsis Group, which is my group that was founded by Marcio Borges here. And this group of clinicians that you see here, with the idea of improving sepsis care. The group had done research into new methods for early diagnosis of sepsis. I will show in a little bit why that's important. And for example, in the last years, they have been working to develop artificial intelligence solutions in order to automatize these early warnings of sepsis in hospitals. But then about 3-4 years ago, I arrived there and I started collaborating with these people, and there was a very good energy, and we decided to join together and become a true translational group. So what we do is we develop technologies to answer to the different challenges of sepsis care. You can see my group on the right hand. I am the technology coordinator now. Marcio is the clinical coordinator. We have one person missing here because this is a picture. But well, it's been a very to date. And now I will show you some of the technology that we have been developed in this institute. So first of all, let me talk a little bit about what is sepsis and what are the issues related to sepsis, because unfortunately sepsis is not a very well-known phenomenon, even now that we have gone through a pandemic. So sepsis is when your body responds in an exaggerated way to an infection because it's an uncontrolled infection. and you start having a lot of inflammation, and your organs start to not work properly. And actually, if nothing is done, you may die in a few hours from sepsis. Sepsis is the first cause of death in hospitals here in Spain. So this is not something that happens somewhere else, and is the most expensive condition in hospitals, because septic patients, even though they may survive, they stay for a long time in the ICU, and they require a lot of expensive resources like mechanical ventilation. I'm sure now all of you are familiar with mechanical ventilation. And so the thing with sepsis is that it's you can get really worse very, very fast. So it's a critical condition similar to a stroke or an ictus. That's why I put here this kind of like mnemonic thing from the Sepsis Alliance. Not everything is about time. Sepsis needs to be detected rapidly, and it needs to be treated rapidly in order to reduce that inflammation, in order to save the life of the patient. And so because of that, actually many hospitals have what is known as a code sepsis, which is a bundle of care protocols that need to be done when one suspects that there's a septic case. And the first challenge with sepsis is to diagnose it. So the problem with sepsis is that at the beginning, it really looks like other sorts of inflammatory processes that are not sepsis. And it's very difficult to identify a septic patient at the beginning. And even if you use biomarkers, I put here a very common kind of like a plot of what are the variations of certain biomarkers during sepsis. We have here C-reactive protein, procalcitonin. And what you can see is that sometimes some biomarkers are high and sometimes they are low. So the problem is that just making one single let's say a test of one biomarker, well, you may get it when it's high or not, but maybe you measure it and it's low, and after 1 hour it's high and you missed it. So this makes sepsis diagnosis even more complicated. And then management. So once we identify a septic patient, what we need to do, take samples for culture, and you need to give venous antibiotics in less than 1 hour. This is the single thing that has been proven to be the most efficient way to halt sepsis. Given adequate antibiotics, and this is important, the adequate antibiotic in less than 1 hour. You probably will also get like some fluid therapy if you have high lactate and things like that. But the antibiotic, if you have a sepsis of bacterial origin, of course, then that's a very important point. Now, problem, of course, is that especially if you acquire the infection in a hospital, and those are the very common beginnings of a sepsis, the pathogen that causes the sepsis may be resistant to the antibiotic that you are providing. And so it will not be effective even though it is provided in a timely manner. So antimicrobial resistance just makes sepsis care even more complicated, because of course we could always give everybody last resort antibiotics, but that would put more pressure into these nosocomial strains, and those antibiotics will become ineffective in a few years. So there's always this trade-off between covering all pathogens or not covering them and risking about outcome. And one thing I would like to highlight is that at this point, there's no diagnostic tool that can detect the pathogen or the mechanism of resistance that can guide the prescription of the first antibiotic, because none of them take less than 1 hour. They all take at least 1 hour, and they are not point of care, meaning that you need to bring those samples to the lab for doing the test. And of course, then you spend even more time in that. Nowadays, all antibiotic prescriptions, the first antibiotic prescription is 100% empirical. Further down the line, when we have the results from the cultures and molecular techniques, maybe they will fine-tune the antibiotic, but the first one, the one that can save your life, is empirical. So I have a very short time to show you what we do, so I will just give you a little bit of an overview of some important technologies. Let's see what we can do in these 10 minutes that we have left. So one of the research lines that we have most advanced is on producing paper biosensors, and these are biosensors made on filter paper. We use gold nanoparticles as nanoprobes, and we use colorimetric methods for detecting the signal. And now I will explain a little bit more about that. So I'm going to show you just a little bit of how these paper biosensors work. First, a little bit what is the interesting part about these paper biosensors. So one interesting part that you will see right now is that these nanosensors, that I even like to call now nanoparticle transfer biosensors, is that one thing we need to store the nanoparticles in the dry paper and you release them on demand. And this is not evident because if you just put a drop of nanoparticles on paper, they become irreversibly attached to the paper, and there's no way to that area, that reservoir, and then detect anything. So we found a method that actually is quite simple. It consists on modifying the paper with a polymer called polystyrene sulfonate. We actually patented this method, and if we modify the paper with this polymer, then we can put a drop of nanoparticles and we can release them with high efficiency. So this is really one of the technology pillars that allows us to detect different types of biomarkers, pathogens, etc., that I will show you now in a second. So just a little bit of how it works. This is one of the latest videos I'm going to show you, but we have even a little bit more, we have done a little bit more of work with this. I hope you see here, I don't know if you see my cursor. If you see this little finger, you can see here in this area, spots. These 3 spots are 3 spots of gold nanoparticles on a paper. The rest is just a scaffold to hold all this together. So when we want to detect anything, what we do is we put a small drop in the middle of another piece of paper. This is all filter paper. And now we dry that sample so that biomarkers, pathogen, whatever we want to detect, they become attached to the paper. Now we add a drop of blocking solution. And immediately after, we just close this and put in contact that receiving paper with our paper biosensor. Now it's the nanoparticles are being transferred from one paper to the other. It's actually not the best video because it got more transferred in one place than another, but anyways, you can get an idea. You see how the nanoparticles were transferred, and now we just wash it. And after we wash, some nanoparticles will be attached there by means of a specific antibody antigens. Okay, so now we get a color dot. So a color dot already could be a visual signal, but we don't like visual signals for many reasons. We like to quantify these signals, and we also have our own on developing methods for quantifying colorimetric signals. We started working with smartphones, and now we can do it either with a smartphone or with a little Pi camera. So our app, because this is what it is, an app, what it does is it guides the user to correctly position the phone so that the distance and the angle are always well controlled. There are some shadow detectors that won't allow you to do the measurement if you are projecting, for example, a shadow on top of the paper. And it automatically finds the region of interest and is calculating the pixel intensity. So this means that you can use this without any sort of a smartphone attachment. I can tell you we have this in the lab. We use it almost every day to detect everything, all the signals that I'm going to show you now, all the biosensors that I'm going to show you were quantified with this app, and so it works actually pretty well. Yeah.
Puede ser este problema. Ahora veremos en la simulación unidimensional esto no lo tiene, porque no hay N.
Someone left the microphone open. Sorry.
Esa la unidimensional.
All right, and so this is an example. For example, for detecting a cytokine, interleukin-6. Interleukin-6 is found at very low concentrations, and it's a very good inflammatory biomarker. So what you see on the left-hand side is a calibration curve with 6 in PBS buffer, right? So just in a buffered solution with this method in less than 10 minutes, and you see we can achieve a super low limit of detection of only 10 to the power 3 picogram per milliliter. And this is great because, of course, what we want is to detect this in real samples from patients. For example, in blood samples, directly in blood, because then we don't need to purify plasma or anything. And because this limit of detection is so low, what we can do is we can dilute those samples. For example, those blood samples, we can dilute them 1,000 times. If with this same method, we are able to detect elevated cytokine levels, for example, in COVID-19 patients. And this is what you see on the right-hand side. We have some healthy volunteers that help us to determine the baseline also of the biosensor. And then we have 2 types of COVID-19 patients, some with IL-6 levels below 10 picograms milliliter and some with IL-6 level above 20 picograms per milliliter. And you can see we can detect these ones with the higher inflammation levels, which probably are developing severe COVID and need to be hospitalized. So just an example of whether we can detect a biomarker with this technology. So this is great, but as I told you before, and one of the important things about sepsis is to be able to provide the right antibiotic as soon as possible. And at least in hospitals, actually in hospitals and in general, 40-50% of sepsis cases, the vast majority of sepsis cases come from infections of the lower respiratory tract. I guess I don't have to convince you why an infection of the lower respiratory tract is particularly severe and difficult to manage after the year we've passed. But the problem actually with these infections is that if you acquire the infection in a hospital, you have almost a 20% chance that you got it from a multi-drug resistant Pseudomonas aeruginosa. This pathogen, the most prevalent pathogen in nosocomial respiratory infections, is resistant to almost all known antibiotics. And because of that, if you have an infection by Pseudomonas, you have a higher chance of dying, and the costs associated to your care will be much higher. So we wanted to develop a technology to detect Pseudomonas rapidly. And because we are talking about respiratory infections, we wanted to detect it in respiratory samples. For example, patients that are with mechanical ventilation, they have a high risk of this type of infection. We can aspirate mucus, for example, and then we can analyze it and see if there's Pseudomonas. Problem with the sputum samples is that they are almost solid, they are very viscous, and the pathogen is in there and it's very difficult to detect it. So we need to find a way to make those samples liquid that was fast and that was very efficient. And so we found this, or maybe thanks to our multidisciplinary view of things and the bio background of many of the group members of the group, we realized that Pseudomonas and many other pathogens produce an enzyme called catalase. And what catalase does is that it transforms peroxide into oxygen, and is so efficient that if you put a lot of peroxide, it makes bubbles. So what happens when you make bubbles is that the bubbles, which are created from the interior of the sample, are going to disperse, are going to mechanically disrupt the sample, okay? As you can see here, on top of the left-hand side here, you see the sputum. This is sputum with buffer on top, nothing happened. Huh? If we add a solution of peroxide in 1 minute, it's completely liquid, as you can see underneath. How do we know that this is because there are bubbles, because of the bubbles generated by the enzyme? Because if we add an enzyme inhibitor, sodium azide, we see that the bubbles are not created and the sputum is not liquefied, doesn't become liquid. This is super easy. You just have to put a solution of peroxide and in 1 minute, you get your answer. I think it's a good example of how engineering has to work. You have to find the easiest solution to whatever problem you have in front of you. And not only that, but if you see underneath this, these things that look like a stem here are actually biofilms of Pseudomonas grown on in vitro. And you see that as the concentration of peroxide increases, you see the images underneath after 1 minute, you see how this stain is being removed, it disappears, and it's because we are destroying the biofilm. So it not only liquefies the sample, it also destroys the biofilms within the sample. And this is important if you want to detect your pathogen with an immunosensor, because, you know, otherwise the antibodies won't be able to detect anything inside that. And so then we use the paper biosensors I showed you before to detect these pathogens, Pseudomonas, in these liquefied samples. You can see on the left-hand side is just the calibration plot in ideal conditions, just to know the limit of detection, etc. So the limit of detection is 10 to the power 6 per milliliter, which is the limit of detection of an infection in the hospital. And importantly here, what you can see is that when we detect Pseudomonas, which are the red dots, they all yielded a positive signal. We detected all the samples with Pseudomonas. These are sputa. Each spot is a sputum sample from a different patient. It's difficult to gather all these samples. As you can see, the green ones are infections by another pathogen. We never get a sample. And if we had a mixed flora, for example, which means that there is a lot of different pathogens, but there's not a very defined flora, we only got 2 false positives. Okay, so this is pretty good, because if you have the infection by Pseudomonas, the doctor will be able to detect it and they will give you the right antibiotic right away. They will never give you the wrong antibiotic. And sorry, this is done in less than 10 minutes, including sample liquefaction. So we have here one of the first tests that actually are useful for guiding the first antibiotic prescription. All right, so besides this, and with this I will finish, I will try to go fast. Another problem that we have when trying to diagnose respiratory infections is that, you know, if the patient is not intubated, it's difficult to get a sample. Not all patients produce a sputum. Or for example, children, it's very difficult for them to expectorate, right? For example, one of these things happened when we had the pandemic, and at the beginning of the pandemic, and we wanted to do something to help, and we thought, okay, we could maybe adapt this to detect SARS-CoV-2 in respiratory samples. Problem is that only about 30% of people with COVID-19 were producing sputum, so not very useful, right? But then we thought of a solution. I was looking at someone talking about wearables for COVID-19 care, and it's like, well, wearables just measure, you know, like things like that are not very much COVID related. But then I thought there's something that we always wear, which is one of these surgical face masks. And these surgical face masks are made to trap the aerosols that we produce so that the virus or the antigens of the virus should be trapped in this intermediate polypropylene layer of the mask. So what we thought is, okay, we're going to just like break this mask apart, which is pretty easy. We'll cut it. We will press our biosensors with nanoparticles that are decorated COVID antibodies, and then we will finish the sensing process exactly as I showed you before. Okay, and we read with our mobile app as I showed you before. So first of all, we wanted to test if this could work or not. So, I did my PhD here, surrounded by engineers. So I'm used to do this kind of like experiments. If Tony is listening, I always feel like I always think about him when we do these experiments. These are the kind of experiments that I love to do with him when I was his PhD student. So I had my PhD student that is pretty smart. I told him, hey, we need to buy one of these spray bottles and we'll fill it with antigens and we'll spray it on the face mask and let's see what we can detect. And surprise, actually, it worked out pretty well. It's quite quantitative. We got quite a nice calibration curve with this, and that encouraged us to go and pick up masks from COVID-19 patients. It was really, really very much an effort. I have to say thank you to the health services who put us in contact with healthcare workers that were confined, and because they gave positive, and some of them were willing to participate in our study. So we went to their homes, we brought them new masks and asked them to wear it for half an hour on the first day, on the third day, and on the fifth day. And we also wrote the days since the first original diagnostic. So directly here, what you see is we also, of course, got some healthy volunteers. And with the healthy volunteers, we were able to establish a threshold value of signals above which we would consider that the person is COVID-19 positive. These are the green dots. And you can see in all cases, we got a true positive except for one. One was a false negative, only in one of those cases. Control experiments made with nanoparticles that were modified with an unrelated antibody, so all like the control, so that's good. And of course, if you calculate the area under the receiving operating curve with this, you have a high number, almost next to 1, 0.99. So very, very useful. And at least 6 of these patients were actually asymptomatic. This was very surprising and very, very nice results. We were very happy with this. And not only that, but actually things can go wrong, for example, which is always good also to test what are the limits of what you're doing. So for example, if the patient had worn the mask within the first 3 days of the official diagnosis, the under the receiving operating curve is 0.99, between 4 and 6 is 0.98, but then if it had passed more than 7 days, then it decreases to 0.70. And this makes sense because it means that your viral load is lowering because you're getting better. And then, of course, it's more difficult to detect those antigens on the face mask. So this is just exactly as any other rapid antigen test. So this, I'm going to just skip it so we have time to make questions. I have time to show you today. We're also working on detecting mechanisms of antimicrobial resistance, and we had a nice research line on wearables for detecting lactate and glucose. But I'm going to be here today and tomorrow, and if you cannot, if we don't have time today for questions, I'll be here if you want to make some questions in person or chat or whatever. So thank you very much, and yes, I'll be happy to answer any questions.
So thanks very much, Roberto, for this very, very interesting presentation, and to let us know how it is to work in a biomedical environment where you've got access to biological samples and do this very nice and very interesting kind of analysis. So if there's any questions, it's time to ask him. You can just type them or just open your microphone and ask yourself.
Can I ask a question?
Yeah, sure.
Very interesting presentation. I enjoyed very much. I have two questions, in fact. Maybe one I missed when you said that you put the nanoparticles on the surface of your paper. They are not covalently attached. I mean, they are not functionalized with something to get chemically attached, or are physically attached.
The nanoparticles are modified. We can modify them in two ways: either with polyethylene glycol, and then we use chemistries to attach the antibodies, or we can modify them with antibodies with physical adsorption. And then we put them in the paper and we let them dry. But the good thing is that they don't attach to the paper. So then when you press it against the receiving substrate, that is either a face mask or another piece of paper, then the particles are transferred to that substrate, and they establish antibody-antigen interactions.
That's why I was thinking how you, if it's chemically attached, how you proceed, no, to put it in the other place. Okay. Mm-hmm. And the other question I have, did you, when you show the bubbles generating with the enzyme, did you were afraid of breaking or damaging at some manner the analytes that you want to measure? Because it seems extremely vigorous, right?
Mm-hmm. Yeah, we actually did some tests with this. We did ELISA in, for example, with just peroxide, because peroxide, there is an oxidizing agent. And you need to, if you don't add too much peroxide, so you need to have a trade-off, of course, then it actually is not very damaging, for example, for the antibodies or for the antigens. But think that we are using here polyclonal antibodies for the detection. And so polyclonal antibodies, they don't care. It is not so important, these things. So for now, we haven't seen any difficulty. I can tell you that we have also detected IL-6 and antibodies against COVID with the same method, and it worked very well.
Thank you. Thank you very much. It was a very nice presentation. Thank you.
Thank you.
So there are some questions in the chat. Murat asks, what are the possible reasons you had false positive negative results?
Reasons in which ones?
I guess in the measurement of the SARS-CoV-2.
Okay.
So you just have one false negative, I think.
Okay. Yeah. So here in the false negative, I can tell you we are pretty sure that it was a sensor malfunction, because we look at the patient, and the patient had symptoms, so it was not an asymptomatic patient, and it had all the clinical, let's say, quadro clínico, all the clinical symptoms of COVID-19. So we think in this case it was that our sensor did not work well. In the case of the Pseudomonas, for example, for the mixed flora, we have 2 false positives. And this may be because there's actually Pseudomonas in the sample, but the culture, or when it was cultured in the hospital, the clinical microbiologists, if they see too many colonies of different kinds, they just say it's a mixed flora. So it actually, and you actually see there's a group of dots here, a little bit like on the, that are around the threshold value, right? So probably all this had Pseudomonas, but probably not enough to be clear infection.
Right, thank you. So Alex asks, how influential is the amount of time you wear the mask for the sensitivity in the measurement?
This is a very good question, because we actually did 2 kinds of experiments. We did with 2 hours wearing the mask and with 30 minutes. And what we found is that if they wear the mask for 2 hours, it is much worse. It is much more irreproducible. The specificity and the sensitivity are lower. And we realized that it is because, I mean, this is like anything. If you wear it only for 30 minutes, you create a monolayer or layer of things attached to the mask, and those things are strongly attached to the polypropylene. But if you wear it for longer times, there are multi-layers, and the other layers are not as strongly attached. So when we do washing steps and things like that, we're loose, it becomes more irreproducible. So yes, if you wait more time, it's worse, but we haven't tried with less time. I can tell you that picking up this mask was a big effort. We had to go in person to these people's homes. Don't think that working with patient samples is easy. Don't think that the clinicians are going to get them for you. The clinicians do just the minimum thing. You have to figure out absolutely everything. You have to press for everything. I have to go to some of these people's homes and pick up the mask. So I think it was kind of a big effort already to try 30 minutes and 2 hours. But now we are working with another type of patient, with COPD patients, actually, trying to detect other things. And I hope that with time, we will be able to do other time points.
Okay, thank you. So Ferran says, very interesting, thanks. The addition of hydrogen peroxide into the samples is not affecting the bacterial cells?
Yes. Well, yes and no, because we only add it for 1 minute. So if we did a test and it's in the paper, if you add hydrogen peroxide for 1 minute and you do a live death assay, most of the cells are still alive. First. Then second, our test doesn't care if because we're detecting only antigens. And third, if the sample has catalase, actually you're not adding so much peroxide. Actually, the cells have catalase to guard themselves against the peroxide. So to recapitulate, in the conditions that we are doing the assay, it doesn't affect the cells too much. I guess if you leave it for a long time, you will end up killing some cells because it is a bedside. But also, yes, to determine what is the real concentration of peroxide that you are adding, because the cells are actually metabolizing it, no? They are transforming it into oxygen.
Okay, so something that I wanted to ask you was exactly that. What was the limit of the concentration threshold that you had to use related to hydrogen peroxide to make sure that there wasn't an excess of hydrogen peroxide in the sample? That's for liquefaction.
We usually add 0.1 molar or 0.3, 0.1, 0.3 to make sure that the sample is liquefied in 1 minute. I don't know, we got stuck with that 1 minute. We could also wait for more. I have to say that some samples are more liquefied than others. I mean, this is not like my than others too. But what I can tell you that is definitely more efficient than the gold standard method, or the method that they use now in clinical laboratories, which includes adding a reducing agent and vortexing for 30 minutes. Mm-hmm. We always get better results with our method.
Okay, thank you. So is there any other question?
Hello, Roberto. How are you? I am Cecilia. Nice to hear you. Very interesting, really, the work you are doing. But I have a question regarding the method of detection. Well, you use the smartphone, okay? But this means that you are doing like a picture, or you are selecting some kind of wavelength, or which is the detection is of the color itself, or of which is the magnitude of the...
Yeah, it's densitometry. So we just detect the color, okay? Mm-hmm. And then what the app does is it finds the region of interest in that white square, which is the sensor, or the outcome sensor, and automatically starts measuring the pixel intensity. It does 50 measurements, and when it has gathered 50 valid measurements, it shows you the average. And that's done really, really fast. So what you see, this is I did this as a GIF, and it's difficult. But you see on top there's a bar. Now there's gonna be a bar that is advancing. Mm-hmm. It's because it's doing measurements. If, for example, at some point you move the phone and there's a shadow or something goes out of range, it stops. Mm-hmm. Okay, but it's using computer vision algorithms to do this. It's colorimetry.
Okay, that's very interesting. Okay, thanks a lot. You will be there tomorrow?
Yes, in the morning, if you're here, I would like to say hi.
Okay, so I will say you hello.
All right,
Okay,
great.
thank you. Bye.
So Murat has got another question. It says, he says it might be possible for patients to exhale directly into the sensor, which is integrated into a specifically designed tool. In this case, a few minutes exhale should be enough.
Okay, we never tried this with exhale breath from patients. I think the good thing about the mask is that, well, I don't know, it has good things and bad things. I guess it could work. We never tried. This is one of the things when I was actually talking to the clinicians, this was one of the things that they thought, hey, maybe if you just like exhale there, I don't know, a couple of times, it's enough, but we haven't tried, but it could be.
Okay. Is there any other question? Just have one more question. Someone else wants to ask something to Roberto? No? But someone was opening the microphone. Okay, no, just one thing related to the mask, the approach, Roberto, is that so you collect the sample with the mask, and then you do all the analysis after the patient takes off the mask. So would it be possible to do the detection while the patient is wearing the mask? I mean, I don't know if on the other side you could just sort of have some, like your sensor that goes through the mask so that you could see the actual colored signal on the other side of the mask, and just by approaching the mobile, you could just carry out the measurement or not?
With my biosensor, no, honestly.
Right.
Now, I've seen some people who are, for example, modifying face masks with carbon nanotubes. Actually, it was one of the first places that appeared in ACS Nano. I guess it's pretty famous. It actually was not to detect things, but I think it was more for like killing the virus or something like that. And I think maybe then you could have some sort of like containment. I think exhale breath, there's a few examples of this in the literature, and it's a very interesting approach to detect. With my method, it's not possible, but maybe with another method, maybe, yeah.
No, one of the good things, I guess, is that even if you have to take off the mask, that you could do the measurement right beside the patient. You do not need anything special to carry out this measurement. I mean, it's just your mobile phone and some solutions. That's for.
I mean, the thing with when we thought about this, the impacting thing that it had at that moment is that if you that it's not invasive, and it's not because it is uncomfortable to do an esophageal swab. It's because if it's not done by a healthcare worker, it's probably not well done. And there was a moment where there was a huge need for antigen tests, and one of the bottlenecks was that there were not enough healthcare workers capable of doing the nasopharyngeal swab. But then what happened is that then the vaccines appeared from one day to the next, and now no one is interested in diagnostics for COVID anymore. And actually, I have this in Sensors and Actuators B. If someone is reviewing this, please let it like flow, because it's been there like for 4 months under the review, and it's like, please just like let it happen somehow. It's like, I think it's pretty cool, right?
Yeah, it is. Papers keep appearing related to diagnostics, and
it's been a roller coaster. Anyways.
It is very interesting. In fact, I think that they try to move all the analysis in nasopharyngeal swabs to saliva because of that. Because getting a saliva sample just by spitting somewhere could be like much simpler, than going through the nasopharyngeal swab. That, as you said, like a sort of trained person should do that to make sure that the sample collection was done in a correct way. So thank you. Any more questions? No? So I think that if there's no more questions, I just want to thank you very much for your presentation. And yeah, that's all. Thanks, Roberto.
Thank you very much. I'll see you
Very
around.
very happy to have you here for a couple of days.
Okay, gracias.
Venga, gracias.